thank you so much for the opportunity to talk about practical and clinical considerations when prescribing long-acting antiretrovirals. And we're going to talk about 4 aspects of this. We're going to talk about clinical trial data on long-acting CAB-RIL. We'll go fast with that because it's been talked about a lot. Then we'll talk about, is there any real-world data on cabotegravir/rilpivirine? How is that put together? We'll talk about some tips and tricks. And then we're going to mention long-acting lenacapavir because there's not just one out there. So, you know, the 3 registrational trials that led to the approval of cabotegravir and rilpivirine, and in the US it was January 2021, and I think it was around the same time in Europe, were FLAIR, ATLAS, and ATLAS-2M. And FLAIR was the study that looked at long-acting cabotegravir and rilpivirine in treatment-naive participants, and then ATLAS and ATLAS-2M, you had to be treatment experienced, you had to be virologically suppressed on oral ART, and then you switched over to long-acting. And the thing about FLAIR, I remember that because it's like FLAIR for new things, you're naive patients. Remember that participants were put on dolutegravir or bacavir 3TC for at least 20 weeks before they switched over to long-acting CAB-RIL. There was actually an oral lead-in period, but there was a direct-to-inject arm, which is why it's approved as direct-to-inject. And then in the ATLAS and ATLAS-2M, you had to be at least 6 months on your suppressive oral ART before switching over to long-acting. So it's not really exactly, you know, de novo going over to long-acting cabotegravir and rilpivirine. There was at least 20 weeks to 6 months of being suppressed. And FLAIR looked good in general. I mean, surprisingly, there wasn't virologic data for quite a high number, but the overall rate of virologic failure was low and the virologic success was high, and ATLAS looked good. And then what was ATLAS-2M? That's just taking the same regimen but increasing the dose to 600 milligrams and 900 milligrams of CAB-RIL respectively, and giving that every 2 months. And then essentially the 152-week data of ATLAS-2M was published in Clinical Infectious Disease last month, and also looks good. Relatively high rates of virologic suppression across all the arms. Still quite a bit of people, who, despite being in a clinical trial where there was no virologic data. So we've talked about this before, but the overall rate of virologic failure across these 3 trials, there was an updated analysis by Chloe Orkin at HIV Glasgow, is 1.4% of the 1224 participants that still they had data on and could follow. And we spoke of this yesterday, Charlotte spoke of this, but really there were specific, it was a very low rate of virologic failure, so that's good. But if you failed hard. And you failed with INSTI mutations, with NNRTI mutations. And the INSTI mutations, we always have to remember these, the Q148, the N155, the G140, and these were the R263K, and these were the main INSTI mutations that came out. And then quite a few NNRTI mutations. It's important to say that the majority of the failures in ATLAS-2M occurred early on, occurred before week 24, and across all these trials, 68% of the failures occurred before week 24. So if you get to week 24, you're likely to do well at that point. Okay, so that's the clinical trial data. So let's turn to real-world data on long-acting cabotegravir and rilpivirine. And obviously, people are using it. We talked about this over the last 2 days. But what would be helpful is if people put reports together and publish them, because we need more data on how we're using this and how it's looking in the real world. You know, before we got these long-acting, we would wax poetic. We would talk a lot about, well, we don't just want these for people who have no problems taking medications or pill fatigue. We really want them like we have long-actings for psychiatric illnesses, for contraceptives, for alcohol and opiate use disorder. We want them in people who, we want to be able to use them in people who have a hard time taking oral medications every day, because it's really that population that is holding 10% of the population is holding essentially 90% of the virus. So it's that patient population that we're so interested in, but the clinical trials didn't tell us how to use these medications in adherence-challenged and viremic patients. And how high is viremia, meaning how hard is it to take oral pills every day? These are the patients that we spend a lot of time with, but essentially across a Lancet HIV study that was published in 2021 across 31 countries, after 3 years after starting ART, the virologic suppression rate is about 65%. So, I mean, nowhere near the 95% that we need to get to by 2030. And the reasons are so different. We talked yesterday, we talked about stigma, and we've talked about forgetting, and I live in a city, many urban centers right now in the US. I think the three major reasons are substance use, housing insecurity, and mental health difficulties. So these are the three reasons that we see most often, but there's so many reasons why it's hard to take a pill every day. So we want to know what they do in adherence challenge patients. And we don't have a lot of data on this. This was presented from the OPERA cohort at ID Week in 2022. And, OPERA cohort is a large US-based cohort, and it turns out that there were 383 people who had been started on long-acting cabotegravir and rilpivirine, and we had data on. And of those 383, 21 happened to be viremic, who had, high viral loads or viral loads that were detectable before starting the long-acting. So that's a very small sample, but of those 21, 19 suppressed. That's 91%, but that's a very small number. And that was a glimpse of some data from OPERA. And then we have two ongoing cohorts in Europe, but these are funded by the drug company. So actually, both of these cohorts are following the instructions by the EMA and the FDA, which is that you have to be virologically suppressed on oral ART before switching over to long-acting. But the Carlos cohort is being done in Germany, ongoing, but data was presented at HIV Glasgow. And among 200 patients, the first 200 patients, the rate of virologic success after switching over from a suppressive regimen was 89.5%. Again, low rate of frank virologic failure, about 2%, but there was a fair amount that they didn't have data on. Maybe it's Germany, but there was perfect rates of, adherence, meaning people were very good about on-time injections. And then the carousel cohort is different European countries, 5 countries, 18 centers. Maybe some of you are participating. And again, same idea, 87% were virologically suppressed, really high rates of on-time injections, 99%. You had to be virologically suppressed on oral ART before switching over. So this is not going to tell us what to do in adherence challenge patients. And then I talked about this, at the first meeting 2 days ago, but we've now published this data in Annals of Internal Medicine, but this is a cohort where we said, okay, once we got these medications at our clinic, which is called Ward 86, which opened its doors in San Francisco in January of 1983. So we're celebrating our 40th anniversary this year, 18 months after the declaration of the epidemic. We wanted to try these intramuscular injectables in patients who had viremia if we just felt like there was nothing else we could do. And so our majority of our patients, they're on what's public insurance in the US. So to be on public insurance, really quite a high poverty level, lots of addiction. We have about a 35% rate of methamphetamine use. That's the drug of choice in the city. And marginal housing was about a third. And of these participants, we put a protocol together, and this protocol is available for download from the Getting to Zero San Francisco website. Anyone can get it, and we refine it all the time. Our next talk today is going to be about different drug levels in different populations. And as soon as we saw some data on that from CROI 2023, we put it into the protocol. So it's an ongoing living protocol, but very welcome to download it. And we wanted to include participants in our demonstration project who are homeless, because really is unfortunately a big problem right now, and 75% of those who are housed in the city of San Francisco are suppressed, but 27% of those who are homeless are suppressed. So we now have 198 people on long-acting cabotegravir and rilpivirine, but the data that we've published I'm going to tell you about 133, the first 133. And we're very well aware of the inclusion criteria of the trials that we just went over, but what we have decided is, again, you don't have to be virologically suppressed to be in our project, but you do have to tell us that you're going to come in every 4 weeks and give us some information about how to get a hold of you, even if you're homeless. Most people have phones, and then friends, or where's your tent. I mean, we really are actually trying to get location information on people to come in. But if you're not touching the clinic, you can't be in the project because we have to see you. And so the one thing that we did is say, okay, who can't be in our demonstration project? You can't be in there if you have INSTI mutations, but we really focused in on the specific rilpivirine mutations and excluded them. And this is the 96-week data from ECHO and THRIVE, which mutations came out as being most significant for rilpivirine. And, yesterday we talked about V179D, Malouche had a patient with V179D. We'd actually let that person in because it was V179I that came out. So we're like really trying to let in some mutations as long as they didn't come out in ECHO and THRIVE as being associated with rilpivirine resistance. So we used our existing staff. So we didn't actually increase our staff in our clinic. We just decided to really put people into this program. We call it the Special Programs for Long-Acting Antiretrovirals to Stop HIV, but that makes it SPLASH. And so this is our SPLASH program. So of the first 133 people started on long-acting cabotegravir and rilpivirine, 43% were viremic, 57% were virologically suppressed, and every single one who was virologically suppressed stayed suppressed. So just like in the clinical trials, they were fine. But then of the 57 who started with viremia, 55 suppressed, and they're still suppressed to this day. We've had now 3 failures, but I described 2 up to the time of the paper. And the 2 failures, one did get snuck in. I mean, it wasn't their fault, it was our fault, but one did have a V179I before we started the long-acting cabotegravir and rilpivirine. And we knew right after the first injection that they didn't have the expected 2 log reduction in viral load. And not only did they fail, but they did develop new NNRTI mutations. And the second patient had a minor INSTI mutation, the T97A, and that patient also failed and developed actually 2 new, the E138, of course, can be either an RT or an INSTI mutation, but in this case it was INSTI mutation. So what about practical and clinical considerations? We've talked about this a little bit, but in this meeting, but the 3 major risk factors for failure in that low percentages of failures in the clinical trials were having a rilpivirine-associated mutations, nothing you can do about that, HIV subtype A1 and A6, but also having a high BMI. So what is the data that shows maybe that's the one factor that we can do something about? There was 2 sets of data actually in the EAC study, in the EAC, meeting. There was an abstract that looked at using 2-inch needles to give the cabotegravir if there was a high body mass index of above 30 was kilograms per meter squared was the failure categorical cutoff. And then this was published in the British Journal of Pharmacology, where you can see that the injection, actually, if there's a lot of adipose tissue, this is given in the gluteal muscle, if you give it with a longer needle, you're getting it into the intramuscular space, and you can see more spread out of exactly what you want. The depot formulation has to be in the muscle. But as we talked about yesterday, actually, they did see an increase in both studies in cabotegravir levels with a longer needle, but not rilpivirine concentrations. So there is something about rilpivirine that I think is harder to circumvent the low drug levels for whatever reason, including high BMI. And then there was one more trial at the CROID meeting that looked at, this is after it was approved, but this looked at switching over from bictegravir TAF FTC over to long-acting cabotegravir and rilpivirine, the SOLAR study. And what I thought was really important in terms of practical considerations is that at baseline, these questions were asked to participants before they switched over to long-acting ART, and 47% of people said, you know, I want this because I'm worried that people will discover my HIV status, or I forget, or I feel that it's an uncomfortable reminder that I have HIV. And this is not like theoretical. They were just about to get on long-acting, and they had very compelling reasons practically to want to be on long-acting. And that's what we've seen in our demonstration project. People have a lot of internalized stigma about taking medications. I was lucky enough to be able to interview the London cure patient, and I said, you have to take all these other medications. I guess you just don't take your HIV medication. And he said, never underestimate what it felt like to take my HIV medication out of my Mediset. So there were compelling reasons why people wanted to be on it. And then just several more practical considerations. You know, it is studied to be given in the gluteal muscle, the lateral part of the gluteal muscle, the long-acting cabotegravir and rilpivirine. But this was data from IAS 2022, and then there was data from CROI 2023 that you could give it in alternative site. You could give the long-actings in the thigh muscle, and if you did that, the pharmacokinetic levels of both cabotegravir and rilpivirine were the same. Now, the thigh muscle, there was more pain. People reported more pain with the injection, but why would you want to do that? Where we've done it is if they're gluteal implants, for example, in our transgender patients, we have also used it if we just think there's the distribution of fat is more in the gluteal muscle. We just really want to get it into the intramuscular space. Sometimes people, you know, it's a privacy issue. It may even open its way to self-injection. So we have absolutely been giving it in the thigh. And then I think the final consideration really got brought up by Anna Marie's cases yesterday, which are these differences in drug levels, which, you know, we don't do therapeutic, well, actually it seems like you do more TDM here, or at least I was very impressed with what could be accomplished in Amsterdam yesterday with the drug levels, but we don't do drug levels very standardly at all in the US. But the thing is about the drug levels with cabotegravir and rilpivirine, especially cabotegravir, is that there is a difference between cisgender women and men. And that difference, we'd already discussed it before, you know, so many discussions leading up to the PrEP, that there was a longer tail in women. And we knew there was a longer tail, and then we got data at CROI 2023 that at least the cisgender women that were enrolled in HPTN 084 seemed to be able to get away with delayed injections. There was more forgiveness of that. So essentially the bottom line of that study was that delayed injections were common and that cabotegravir concentrations were above the PAC IC90 for prevention in over 90% of patients, even if you went out to 6 to 8 weeks or even 8 to 10 weeks late. So that really indicates that at least in HPTN 084, which is again the cisgender women study, that there were a lot of high drug levels even if you really delayed your doses. And I think it does suggest PK forgiveness. I think it suggests that either cisgender women or maybe African patients, because importantly, HPTN 083 was multiple sites, but HPTN 084 was essentially conducted in sub-Saharan Africa. So I don't think we know quite if it's women or pharmacogenetics. We don't know why, but there is higher levels in HPTN 084. And it leads to me this intriguing idea, could we ever give it every 3 months in women and give it with injectable progesterone for contraception? But we do need more study of that. And then we'll get data in the next talk about variable drug levels, but there was this other study presented at CROI that in 2 French university clinics, 88% male, so not women, but when they started on long-acting cabotegravir rilpivirine for treatment, a specific group, those who didn't get the oral lead-in and had high BMIs, and Anna Marie's patients yesterday did not get the oral lead-in, both of them, they had lower drug levels than expected. So you know what we're doing is that not only do we give the 2-inch needle for the BMI, but we also actually give 2 weeks of an oral lead-in concomitant with the injectable, not cabotegravir or rilpivirine as an oral lead-in. We don't see a point of 2 drugs and low genetic barrier resistance, so we give whatever oral ART they were on, and then give the injectable at the same time and then stop after 2 weeks. We're scared about this low levels in the first 2 weeks. And then I'll end with the summary of resistance mutations that came out in from HBTN-083, because this was data that was just published in Antimicrobial Therapy in April 2023. And, you know, like we talked about yesterday, there weren't failures in HBTN-084, but there were 10 failures either in the HBTN-083 or the 1-year open label extension of OHA3 and HBTN-083. And, you know, there were a lot of people, despite on-time injections, that got these mutations. So we're really looking at all these bolded mutations as concerning mutations for cabotegravir resistance. So we would never start cabotegravir if any of these mutations are present. But all these mutations that are coming out are the signature dolutegravir and bictegravir mutations. I mean, you've really lost those medications. I wouldn't double the dose unless you had just one mutation. So I think that's concerning. That, you know, at least in men and transgender women, there is this. There's something about, you know, it not having the highest genetic barrier to resistance. And then I'm running out of time. So, you know, we've talked about long-acting lenacapavir. I just want to say that we're not going to, from Calibrate, which is the long-acting lenacapavir with different oral medications, this cannot be pushed for a naive indication yet, because this is a phase 2 study. So these are only 51 people in lenacapavir along with BIC or TAF, or taking away the TAF FTC and just showing BIC. But importantly, in Calibrate, there were 3 out of 157 participants who did fail with resistance. And there's something about this drug, and we saw this in Capella, that you need to have a backup. You cannot have lenacapavir by itself. The Capella study, of course, was the MDR HIV study, and this was already published in the New England Journal, the results that we can certainly use lenacapavir in multi-drug resistant HIV. But I think it was really important to remember what happened at ID Week, that the participants who failed, and there were only 72 participants in Capella, and a full-on 9 failed. That's a lot. And of those that failed, every single one of them, they had done drug levels, and they hadn't been taking their other medications, or they didn't have another medication to really to pair it with. So lenacapavir, the minute it's alone, it seems to immediately get resistance mutations. So never, ever think of lenacapavir as being a minute alone, I think. And I think that's really important. It has to be paired with other things. And these are the signature lenacapavir mutations. So I'll end there, and we'll take questions. Thank you so much.